Welcome to the Care Social, the podcast where we discuss the biggest topics in social care right now. Whether you're a health and social care provider, a frontline worker, or just passionate about making a difference, we're here to bring you expert discussions, insights, and real stories from the sector. I'm Barry, Content Operations and Delivery Manager here at QCS. Today, I'm joined by Jackie Poole, a leading specialist in dementia care, as well as a passionate campaigner, author, presenter, and inventor who has shaped the way we understand and support those living with dementia. Jackie, thank you so much for being here today.
It's a pleasure. Thank you for inviting me, Barry.
So for those that don't know you, which probably going to be really few people now, give us a brief introduction to you and your journey into dementia care. Let's not talk about your retirement, but let's talk about the fact that you're not winding down after retirement, you're ramping up.
Yes. Okay, so thank you. So, well, it goes back, it's a long story, and I'll give you the short version, otherwise we'd be here for hours. But back in the early 1980s, I got a job as a occupational therapy support worker and assistant in what in those days was called the psychogeriatrics unit. So it kind of tells you a lot, or just with that kind of phrase, up in Liverpool. And my role was to entertain really the patients there who had dementia. I got to know them really well because I was spending a lot of time with them. And although initially I could see only the difficulties that people had, and that was mainly how they were related to by the professionals working there, I began to see that people had abilities too. I started to get a bit cross, to be honest, Barry, about how people were overlooked right back then.
Yeah.
And so I decided the only way I was going to manage to do something about it was if I got myself a profession as well. So I actually had, well, I didn't have the right qualifications. I had to do evening classes for a bit to get the right qualifications to then go to college, to occupational therapy college, to train as an OT. And then when I came out of there, I did my usual, most OTs do like what's called a basic grade rotation around lots of different elements of care. So hip replacements and spinal injuries and children's services. But apart from the children's services, most of them had older people coming as patients. And what I discovered there was, again, that anybody who'd got dementia was just kind of bypassed. It was assumed that they wouldn't be able to benefit from the rehab. And often it was assumed that because they were going to be discharged into a care home, there was no point in giving them any therapy. And again, that kind of got me bit cross, so I decided I needed to really specialise, and my first role was Wales. We moved to Wales, my husband and I got a job in a cottage hospital in Wales, and it was a real treat in a way. I mean, I don't think you get this now, there was only 16 patients in the hospital, and I was a full-time occupational therapist working with them. And they'd never had an OT before, and to begin with it was a bit of a trial actually, because the nurses mainly, but the other staff didn't really get what I was trying to do, but they really began to get very enthusiastic when they saw the difference that some therapeutic input could make. And alongside that, I started to read a bit, well, kind of fast forward a bit, 1990s, early 1990 actually, I saw an article written by a man called Tom Kidswood, which a lot of people, I hope, know that name now. He was writing about what was called the dialectics of dementia. In other words, all the different facets of what dementia is. And I read this article, which was explaining that the whole person-centered equation, that to be person-centered, you've really got to understand everything about that person, not just what's happening in their brain, but what's happening emotionally and socially and physically and mental health and physical health and so on. And I read this article and I got really excited because I thought, wow, this is exactly what I'm thinking. But I was a bit concerned because what I was beginning to see was that people were really diving into the kind of social psychology and missing out often what's happening in the brain. And that's, to me, is critically important too. It's not, not one weighed up against the other. And in those days, there weren't computers. I actually hand wrote to Tom and said to him how excited I was. And he wrote back, and we ended up having this dialogue backwards and forwards by letters to begin with. And then he invited me to work with him. And so I began to work with him. I started to speak about what I was doing at conferences. People asked me, could I run a course on that before I knew what had happened. I was running a training organisation. I had 16 trainers working with me, and we trained in dementia care all around the country. And because of that, I got asked to get involved with the National Framework for Dementia that the government developed back in the late 1990s. And I wrote the framework for dementia training for that all dementia training now follows. I got commissioned by the government body that was developing training rules and frameworks. So so it's been quite a varied journey, and I've written about different aspects of dementia. I've delivered training, I've spoken at conferences, and as you said, I'm now working a lot in research, particularly around rehabilitation.
Let's talk about what you think then. What is good dementia care? What are the foundations?
Yes, well, I suppose I've already started to touch on that with the whole concept of person-centered care and truly person-centered care. So you need people who, no matter what profession we're in, you need to have empathy. You need to be able to have emotional intelligence, to be able to read the body language, read the tone of voice, understand the background of that person and why they might be behaving in the way they are. Because of their difficulties with their cognitive processes, what depending on where in their brain has been damaged, they might not be able to communicate through their spoken words, but they often will through other ways, other types of language. So empathy is really important, and compassion goes with that, I would say. And then on top of that, there's skill. You can't just deliver care to people with dementia without having done the training and understanding what's going on for somebody. I think any other field you would expect to be treated. If it's somebody had cancer, you would expect to be treated by somebody with the skill that understands that cancer, understands the process, understands the symptoms and the impact on the person and their family. And I want the same for people living with dementia.
What can providers do to move that on in terms of providing good dementia care? The biggest thing at the minute is around safety, isn't it? The
Yeah.
balance between safety and promoting independence for those people that are living with dementia. What advice would you give to providers to get that right?
So I would say training and learning is really important. And I don't feel that e-learning on its own is enough, but there's different ways of going about learning. So you could start off with some e-learning to get the basics of understanding, and then you could do in-house group learning, discussing and understanding together an individual. No one person, I don't think, can see everything about that individual and really truly know them. You'll often find that the night staff know something that the day staff don't know. And so you need people to communicate with each other and really hand over the little nitty gritty pieces of information that make all the difference. And when it comes to safety, of course, safety is important, but we've got to consider psychological harm just as much as we do physical harm. So we worry about people potentially having, falling because they're a bit wobbly on their legs, or they've not been able to remember that they've got, I don't know, a hip replacement and they shouldn't be walking, or whatever it is. And so the problem is then, I think, that quite often the care teams will try and keep that person sat down because then they're going to be safe from falling. But the psychological harm of that is immense. People feeling restricted, people feeling that they're not able to do what they want to do. So, of course, the solution is to help people to move, but to move safely. And so the problem, of course, currently is about the cost and the number of staff, because what that requires is to plan in that there is somebody who is planned in on a regular basis throughout the day to go and accompany Jeff or Brenda or whoever it is for a little walk, an accompanied walk, so that they get their walk, they enjoy an activity of chatting while they're doing that, and they're going to be safe at the same time. So it's a kind of a balance, isn't it, of thinking about both sides and not just cocooning people.
I've worked in services, when I went into dementia services, and people were in bucket seats that were tipped right back, so people couldn't climb out, and people sat in the wheelchairs with the straps still on. So that they couldn't get out. And it is a real culture shock sometimes when you see that.
Yes.
But then one of the things that I quite like is that the real drive at the minute for mandatory training and dementia being mandatory training. So what do you think about that then? E-learning isn't appropriate for dementia all the time, because what it misses and what it lacks is that experiential training that I think people really need.
Yeah. Totally. I just totally agree with you, to be honest. I think you can do the learning for understanding about the brain and how, memory. We need to go quite back to basics, really, because people get confused about what are the symptoms of dementia and how they impact on people. And, they talk about memory, they talk about short-term memory. I used to do a lot about memory in my courses and get people to understand the different types of memory and how some types still work when others don't, and how you can tap into the bits that do work, rather than only seeing the problems. When I did a piece of work with a large local authority, one of the things I did was to reframe their care plans with them, because they were problem-oriented care plans. So they identified what the person had problems with and then what they needed to do to get around that problem or protect the person from that problem. So an example was, it would say, the one said that somebody isolates themselves in their own room, and that was seen as a problem. And the solution, the plan, was to get them out of their room. But actually, this person enjoyed time alone. And I got them to think about, if that was seen as the ability, they choose to have some time in their room, then the plan would be to protect that time, not to leave people just sat there all on their own. I mean, you'd go and visit them in their room and you would encourage them to come out occasionally, but it shouldn't be seen as a problem. It should be seen as a positive choice.
And that's where I think life histories are so important when people are coming into services. And one of the biggest problems is getting family members to fill them in, or somebody that knows the individual well enough to fill them in.
Oh, yeah.
Because if you've got a really good life story, you know that Betty doesn't want to come out of a room. Betty's always sat in a room and read her magazines. You can't just force her out of that room into a communal environment, because that's not what she's used to. That's not what she wants.
No, totally.
But getting the life history completed can be a real challenge for some people.
Yes. You've got to kind of think about where you could get that life history from, because obviously some people don't have any family, but there are others, and they think we get a bit more kind of creative about that. So if somebody's, often before they've arrived in a care home, they've had home care, tap into finding out from that home carer. They'll know them pretty well, and find out if there's any information. And also see life history as a living document. It's not just what happened before, it's keeping it up to date with what's happening now as well, and adding to it. Absolutely. I think that's important.
Yeah, and I think that's where, when you get a really good care plan and you've got people around me that are important, making sure you've got birthdays so you can acknowledge them bits, and it's all stuff that brings people back a little bit, and sometimes I speak from life experience with my mum and people I've had in my family with dementia. So Jackie, tell me, why does language matter so much then? What are some of the really positive examples that can make a difference when supporting somebody living with dementia?
Well, I think language matters. There's different ways of looking at it, I suppose. I sometimes wonder, does the language that a person uses reflect the attitudes that they've got? Or does the language that they use just reflect habit, and that they're picking up on what everybody else is using and haven't really thought about it? Either way, it's not good, unless they're using really good positive language, obviously, which is what we do want. Yeah. And I think I was thinking about some examples for this. So if people are trying to connect with somebody, they've got to be very careful that, for a start, the language that you use, you tend to use different tone depending on what type of words you're using. So if you are wanting to show that you are empathic and that you are understanding of that person and you're there to support them, if you use words that give that message, and actually what will happen, not only will it come out in the tone of your voice, it also comes out in your body posture. And even if the person doesn't understand the words, they will get the tone and the posture and feel less threatened. And it's when people feel threatened that they start to stand up for themselves, which other people might call aggression. But I think it's when people have been, classic, somebody has been incontinent. If a care worker goes to that person and says, "Oh, you're really wet. If you've had an accident," all those kinds of let's get you changed. Immediately, there's a power thing going on, which will show in their body language and in their tone of voice, because they're taking control. But if they were to suggest to somebody, I can see you're uncomfortable, you're showing concern. You're not naming the behaviour as being, you're naming how it's impacted on that person. I can see you're uncomfortable. Would you like me to help you get more comfortable? Is a much nicer way of saying, I'm going to help you get out of these wet clothes, without actually saying, I'm going to get you out of these wet clothes, which is going to put somebody's back up.
Because you're offering support, you're not giving them an instruction.
Yes, yeah. And you're saying we're working together on this, not I'm going to do something to you.
And you're also giving them the opportunity to say no.
Yeah,
So
yeah. And then you
yeah.
will say, I'm really sorry, I'll come back later. Yeah. And give it a little while, and then see if if the person will accept that help a bit later on. And often they will, or it might need somebody else to go and offer that help whose face fits a bit better, because people have preferences, and we just shouldn't get kind of wound up about that if our face isn't fitting that day.
And I think that's one of the things people don't understand sometimes, is that you don't like everybody you meet. I don't like everybody I meet. Yet sometimes when we're in services, they don't have the option.
No.
So a change of face for somebody is all it takes in many occasions. But when you're short-staffed and that you are the person that they're saying.
Yes.
And if they don't like you, you're going to get that feedback, and you're going to get that behaviour, because they don't want you around them.
Yes.
So that body language and that posture and that gut feeling you have. Somebody living with dementia still has that gut feeling. If they've got a gut feeling that you're not the kind of person that they would like, you're going to get the response that person would always give.
In fact, more so, because if that person can't reason and think through, they're going to purely react on that emotional instinct. So I'm just thinking another little example is if a word isn't working, try a different word. So I'm a northern lass, so I would say bath. But if I'm living, as I live down in the south and have done for a long time, I still say bath. But if I was talking to somebody and I was suggesting about helping them to have a bath and they didn't understand that, I would actually change my language and try to say bath, because then they might get it. I was walking down, I still remember it, walking down a corridor in a care home, and I heard bedroom door was slightly ajar, and as I went past, I heard somebody saying, very distressed, a gentleman resident saying, I don't want to, he was saying. And I think, what's going on in there? And then I heard the care worker saying in her very loving, caring voice, I'm just wanting to take your dentures out. I don't want to was coming back. And then, oh no, sorry, beg your pardon. She said, I just want to take your teeth out. That was it. I just want to take your teeth out. And then I put my head around the door and kind of, and she came out, and I said, try suggesting to him that it's his dentures you're going to help him to clean rather than teeth. And when she went back in, that worked. But because it was, he genuinely, I'm sure, thought he was going to have all his teeth removed, rather than just having his dentures cleaned. And we've got to use the language that people get, rather than just using words that we think are right.
Yeah, I remember a really intense CQC inspection once in a service in Barnsley, just where the miners' strike started originally. CQC inspector was she didn't miss a trick, which was good in the service, and pulled up on the staff because they were using the words cocker. And they were saying, oh, well, such and such in his bedroom, and he's absolutely sock on. There was lots of different language coming out. And she actually challenged the staff on the use of language. And one of the guys that worked for me at the time, ex-miner, and he said, well, if I talk to him the way that you're talking to me, he's not going to understand me. He grew up here, and this is the language that we use. And I stood there and I thought, oh my God, this inspection is going to go downhill really, really quick. And she thanked him for challenging her back, and said, you're absolutely correct.
Yeah.
And she turned around, she looked at me and said, is that in the care plan? And I'm like, no, but it will be.
Yes. And it's important, isn't it, that the care plans have for each individual. So, because the risk is that everybody uses the same language for everybody. And just because they're all living there doesn't mean to say that's where they're from. Then it's about individual. You can't kind of say it often enough, really. It's about each individual and having a really good care plan. Which is more... I mean, care plans often say what team members should be doing. What they don't usually say is how, and it's the how bit that needs to be embellished.
Brings us on really neatly to the PAL assessment tool.
Yay!
This is where we start to get care plans right, isn't it? And we start to get that key information into the people who need it most. So tell us, what is PAL? Tell us why you developed it and what it's all about.
Okay. I was doing a piece of work with Tom Kitwood. He wanted me to just write a book, he said, which was a bit of a challenge, which was about helping people to do things for themselves. At the same time, I was also doing a piece of work with a local authority where they had got They'd actually got a year's grant from the Alzheimer's Society to employ an OT, an occupational therapist, who was going into the care homes and working with the activity providers to deliver meaningful activities for individuals. And they wanted me to oversee the whole programme, so I was supervising and supporting the OT. Now, the OT was using a very specific occupational therapy assessment, which requires, it is an assessment and then requires the OT to use their skills to interpret what those results are. And they were working with the activity coordinators then to put that into the care plans and to deliver the activities. But I was thinking, well, that's all very well, but in a year, when this grant has run out and that OT's gone, what are the activity coordinators left with? Because they won't be able to use that assessment and interpret it, because it's, you've got to have that training, and the training is for OTs. So the two things kind of came together, really. And I thought, well, what I need to do is think about how can we have an assessment that self-interprets, and rather than requiring somebody to draw information from it, it interprets and it produces a guide that helps people to know how to present the world to somebody so they can do things with the level of ability that they've got. So it is based on the original occupational therapy assessment, which is by an OT from over in America called Claudia K. Allen. But then it draws on other psychological tools as well, and a bit of my own kind of thinking as well, all involved together. And I developed it, obviously tested it out in that particular study, spoke to Tom about it, and he was really encouraging it. He said, oh, I think we've got 2 books now. So I ended up with one on the PAL and one on the kind of more general doing things. We tested it out, got feedback, tested it out in lots of different areas, started and published it, but it wasn't an evidence-based tool. Then we published it, and then people started to use it because they found it helpful. And then the UCL, University College of London, they wanted a tool to evidence how activities were impacting on residents in some care homes that they were doing a research study in. And there wasn't an evidence-based tool, so they took PAL and they tested it out for a year and gave it its reliability and validity test, which it passed, which was a bit scary. It's like having your child put under a microscope. So it was a bit scary, but it actually passed. And so it is now an evidence-based tool. And actually, it's called the Pool Activity Level Pool, because that's my surname, Activity Level, because it's about ability, instrument, because it's got in it the cognitive assessment, which you answer 9 questions, and it's done either through observation or through, people have actually sent it to family members and got them to fill it in as well. So it's done about somebody, about how able they are in these 9 different types of activities. 3 of those are activities of daily living, so getting dressed, having a wash, having a meal. 3 are more social activities about communication and talking to people and working in a group. And 3 are about how the person engages with objects and how they do things. And all 9 questions have got 4 statements about how that person does that activity at 4 different levels, from only just very mildly affected by their symptoms of dementia through to quite severely affected. So it categorises, if you like, the person into a level of ability and then produces a guide about how to help the person in whatever activity you're doing at that level of ability. And the PAL book, I happen to have one here, just a bit of shameless marketing is always good. So this now is the 5th edition of it, which is actually the QCS PAL instrument, because the QCS, Quality Compliance Systems, obviously, they acquired PAL, which I was really delighted, because I was planning my retirement and I wanted to make sure PAL kept going and was still available to people post-retirement. And so I was really delighted when QCS took it over. And it's got also in it, it's got a life history profile for people who don't know how to collect life history. And it's the last piece of work I did for it was an outcome measure that again has been validated. So you can use it in research, or if you just simply want to evidence the impact of what you're delivering in your service. Not just for leisure activities, but all activity if it's done well. So, having a wash, getting dressed, having a meal is my favourite activity. And I think, their activities too.
Just for those that are listening as well, I will share an image of your book and I'll share the link so that people know where to find it as well. So that's really good then. What advice would you give to some of those care homes that might be coming across the PAL tool for the first time, and their care teams when they're starting to use it for the first time?
So And if they get the book will explain, and it's got lots of examples in it. So that's one way. Or if they subscribe to the Dementia Centre at QCS, there's all sorts of training tools on there as well, of course, that would help them. And there's a train the trainer tool too, so they could cascade that learning within their service. When they start to actually complete PAL for residents, the best way is to get together as a team and discuss the levels, understand what those levels mean. And the way I've always done it is then get the team to think about a resident that they know well. And first of all, say what they think in terms of those 4 levels. Where do they think this particular resident is in terms of their level of ability, of the description that they've had? Then complete together the assessment. And it doesn't take long, 10 minutes, I would say. It might take a bit longer if everybody gets heated in their discussions. So you go through each of those 9 statements and say, okay, so where do you think Betty is in these 4? And what you'll find is that people disagree, which is interesting. So people haven't got a consistent understanding of what somebody can do. Often you'll find that people say, oh, no, she can't do that. Oh, yeah, and then somebody will pipe up, oh, well, she does that for me. Now, the thing is, if somebody can do it, they can do it. And so, don't ignore that. Put that down as their level of ability, and it's up to the staff then, the team, to bring themselves up to speed, to do whatever their colleague is doing that brings the best out of Betty. Discussing it as a team is the best way of completing it. And also, not only because you've got that team knowledge, but also you've got then the buy-in to using the guide afterwards because everybody's felt involved. You don't just have the manager sitting completing it in the office and then telling people what to do afterwards. Get people involved in the assessment so they've got an understanding then of why you're now producing this guide. And the guide comes in 2 formats, actually. In the book-based version, there's a simple guide which really just explains how to present the world to somebody when they're at that particular level. In the Dementia Centre, you've got a much more comprehensive guide which has broken that down into each of the different activities. So there's a guide for helping somebody to get dressed, there's a guide for helping somebody to have a meal. And what you can do, of course, is then split that guide out and make sure that the leisure activity bit is for the activity coordinators, the dining bit is for the dining room team. So everybody has got the bit of understanding that they need, or you can keep it all together as one guide.
What I like about the tool is that when you pick it up for the first time, like I did, you're reading the 9 different sections, you're reading the questions, and you think, oh, that's not difficult. It makes sense. It's written in a language simple enough for everybody to understand. So there's no big words in there that people are going to get confused with.
No, I don't use big words.
Everything in there. No, that's really good because everything that you see in it for a carer or a support worker or an activity worker, anybody that picks it up, and even a family member, like you're saying, they can relate to those and they can say, oh, well, actually, we're here or we're here. So that's really good.
Yeah. Well, as well, Barry, I used to do, if you've got people listening who are home care, which I'm sure you will have, it's quite interesting to do your assessment, the PAL cognitive assessment yourself, but also give it to, if this family member's supporting, give it to them and ask them to complete it or complete it with them. And just see if there's a difference between what you know and what they are saying, because that will help you to understand how to support that family, because they might be have too high expectations or too low expectations of where that person actually is in their ability. And sharing the PAL guide with them means that when the home carer is not there, the family carers hopefully will be able to use the same approaches.
It's also good if you're starting to support somebody where the family can get them to do something that you can't get them to do.
Yeah.
And that's knowledge that you really want to get.
Yes.
Because it's like we were talking earlier about the change of face. They'll do one thing for somebody else, but not for another. If you find how that person's doing it, you can then replicate that and put it in, which means your care plan is going to be so much better.
Yeah, totally. And also the team includes the family. And so they feel part of it. Then they're not just being, they are looking to the professionals for skills and knowledge, but they want to feel included as well, I think. And so that helps to do that. And the other thing is, if it's in a care home and you've got family coming to visit, I've seen so many despondent family visits where they kind of arrive, they share a piece of chocolate with somebody, and then they leave looking very dejected because they've not been able to relate, not been able to do something with their loved one. And helping them to use the PAL guide to do a little activity together or to have a meal together in a meaningful way can make all the difference to that visit, and means that the person will come back more.
I've seen some great interactions in in care homes where they actually allow family members to book in for lunch, and sit and have the meal with the family members, and it's so nice.
Yeah.
It
I
just
always used to
changes the
join my
dining
mum
room
for lunch in
experience
her
around
home.
completely.
Yeah.
Yeah, and it was good food as well. So
Oh, yes.
yeah.
There was one day though when where I went and had a meal with Mum, and there was a lady and a gentleman sitting at the table too, and the lady just sat and looked at her food and nobody came, and she just sat there, and before I could do anything, actually, the gentleman leaned over and scooped all her food onto his plate and ate it, and then the care worker came back in and said to the woman with her empty plate, "Oh, did you enjoy that?" and whisked it away. I mean, you have to be there in the room. You cannot just give people food and walk off. So we talked about language earlier on. One of the negative words is feeding, and I would actually, please forgive me this, you might want to cut this bit out, but I call that the F word in care, to talk about feeding.
Yeah.
So
everyone would relate to exactly what you've just said.
Yeah. So the word should be dining. Yeah, helping people to dine. And you can only do that if you sit down with somebody and dine with them. And actually doing that often will prompt the person, because it feels more like a social occasion, that if they see you eat, they're more likely to eat. And you can keep an eye on people's intake as well, of course.
Absolutely. If you look at it as that experience where it is a social thing, people sit down and eat together, that's what families used to do.
Yeah.
So to make it an occasion where people sit down and eat together, you can get a lot out of it. You can get a lot of quality interactions out of it. But just on where you're talking about the F words, one of mine is softs.
Oh,
I hate it. Absolutely hate it. But they're out there. We'll get rid of them at some point. We just keep having
so any word that describes
bang away at the drum
by a need is wrong.
So what others, just before we move on, what other words would you? So I have walkers.
Oh yes, well yes, there's all those again described by words. Nappies, I've heard people describe the babies, all those. But I'm hoping that's gone now. But it doesn't do any harm just to call it out, just in case.
It's about having that positive culture, isn't it? If the culture is committed to eradicating them, then they do get eradicated. So
yes.
Okay. Well, that's it for this episode of the Care Social. Join us next time for part 2 of our Jackie Poole specials. If you found this podcast helpful, share it with your colleagues. Have a topic you'd like us to cover? Comment below or email us at qcs@qcs.co.uk. Until next time, keep delivering outstanding care and support. Thanks for listening.